Hello, and welcome to this morning's session, live plenary on urgent and emergency care, the contribution of research. My name is Helen Snooks, I'm chairing today's session, and our presenters today are Alicia from Sheffield University and John Browne from Cork University in the Republic of Ireland. During today's session, you're able to answer questions by going to the Q&A button at the bottom of your screen. Please type in your questions here, and panelists will answer the questions at the discussion section at the end of the session. We'll get through as many as possible. We won't probably be able to get through them all, but to help this process, you can upvote questions by liking them. This will mean that the most popular questions will rise to the top and we'll take them first. So to begin today's session, I'll just set the scene. What are the issues in emergency and urgent care provision? Most people use emergency care very infrequently in their whole lives. Some people use emergency care more than others. Overall, there's rising demand and there are problems in the capacity of the system. We all want the emergency care system to be there to respond to when we need it. But the urgent and emergency care system has to respond to such a wide variety in terms of case mix, condition, severity and urgency, and needs to provide safe care with people at very different distances and with a variety of professional skills in the emergency and urgent care system. So the system is responding, but there are many uncertainties. Should there be more centralisation? Do economies of scale work in this situation? And whose outcomes are we measuring? There is sometimes a mismatch between evidence and policy. And we're going to hear today from two speakers who have had a long track record and history of working in this area and providing research. They're going to talk through with us the contribution of research to this area of care. I'll pass over now to Alicia from Sheffield.
Hi, I'm Alicia from Sheffield, and today I'm going to talk about one aspect of the urgent and emergency care system, which is managing demand. Here's a wonderful diagram of the system produced by the King's Fund, and this is the system within the UK. The right-hand side of the system is around when you get into a hospital bed, you're a hospital admission, and everything that might happen before and after that. And John Browne will talk about emergency admissions later on in the session. I'm actually going to focus on the left-hand side of the system, which is more the urgent care of this side of the system, where the patient is making decisions about whether they have a potentially life-threatening condition, or they feel that they need to see somebody that day, and they decide whether they are going to call 999, go to see their GP, head on up to the emergency department, or use a walk-in centre, for example. Now, before we talk about managing demand for the system, I think we need to look at what the demand is. Now, Helen did say people use emergency and urgent care infrequently, and that is the case, but nonetheless, demand for the service is absolutely sky high. England has a population of 56 million. In 1 month, almost 1 million people call an ambulance service. That's 1 in every 50 people. The same is true for going to an emergency department, using a minor injury or walk-in centre, or calling NHS 111. Now, I've had to estimate the use of same-day GP for sort of urgent care. But if you look at the utilisation of urgent GP care, that's even larger than all the other services put together. So we're in a situation where these services are working incredibly hard, dealing with so many people on a monthly basis. And yet in the press we see issues around ambulances queuing up outside emergency departments, overcrowded emergency departments. And when we look at the graph on the right hand side of this slide, the National Audit Office looked at demand for ambulance services over a number of years and looked at the increasing demand. They also showed that resources did not increase at the same rate as utilisation of the ambulances. So what can we do to manage demand? Well, something that people have focused on is patients who arrive at these services, emergency ambulance, emergency departments, GP urgent care, from very minor or non-urgent problems. And policymakers and service providers have developed a number of innovations to help address these non-urgent use of the urgent and emergency care system. And I want to talk about three types of innovations that they've introduced over the years. First of all, offering new alternatives to these three big services. Secondly, trying to divert people using triage. And thirdly, generally trying to reduce demand. So for this first strategy, one of the examples that we've seen in recent years is the introduction of walk-in centres. So instead of going to an emergency department with a minor health problem, you can go to a service that is open from 8 in the morning till 8 at night, 6 days a week, and where you'll see a nurse or a doctor. As we saw in the previous graph, there's about 1 million people use these and minor injury units every month. And yet, if you look at the impact it's had on the use of emergency departments, the evidence has shown that there has been very, very small drop or absolutely no change. So what we have here with this innovation is the possibility that it has simply got supply-induced demand, or it may be that it has met an unmet need because people are using walk-in centres instead of accessing their GPs. The second strategy is to try and divert people to different services using triage. And one of the biggest innovations in the UK was the introduction of NHS Direct, which offered a nurse-led triage service so that somebody in the general population could call up with a health problem, speak to a nurse who would direct them to the best place for them. That was replaced in England by NHS 111. And the hope was that we would see reductions in use of emergency ambulance services, emergency departments. Now, the way that policymakers introduce innovations like that is usually to introduce them into 3 or 4 pilot areas, and then they ask researchers to evaluate those pilots. And here are 3 graphs of 3 pilot areas for NHS Direct. And the lines on the graph are the utilisation of ambulance services, emergency departments, and GP out of hours before and after the introduction of NHS Direct. And what you can see there is absolutely nothing changed in terms of use of these services. A later analysis showed a slight reduction in use of GP out of hours. If you look at what happened to services when NHS 111 was introduced, again using pilots in 4 areas that were then evaluated by researchers. Here's an amalgamation of what happened to emergency and urgent care services, the change before and after the introduction of NHS 111 compared with controls. You see there's very little going on, except there is a reduction in the use of NHS Direct, which was actually running alongside NHS 111 in those pilots. But you also see a slight increase in the use of ambulance services, and there was actually a 3% increase in emergency ambulance services, when the intention of NHS 111 was to reduce the use of ambulance services. So what are the problems with introducing a service like this? Well, I mean, I think first of all, if we didn't have a service like this, I would probably want to introduce it. But it's also the case that making assessments by telephone is inherently risky business, and people tend to take a cautious approach. The other problem that we face is that we have introduced NHS 111 to help manage demand for other services in our system. And yet the demand for that service is now outstripping supply, and we need to think about ways of managing demand for the service that was put in place to manage demand. So NHS 111 online has been introduced, first of all, into pilot areas, again, evaluated by researchers to understand exactly what benefits it gives to the population and whether it can help manage demand for the 111 telephone service. The second type of triage that service providers have actually introduced is if we've got problems in our emergency departments with patients arriving who really need to see their GP, well, why not use general practitioners within emergency departments or alongside emergency departments, and then triage patients to the best place for them. And we've had a number of models developing around England, and Jonathan Benger has led a research team to exploit that variation in innovation around the country and try and understand which models are the most effective and efficient models in use. The third approach to triage can be when services themselves decide that they're going to triage patients who come to them. And the emergency departments have been doing that for decades. But I'm going to focus here on the ambulance service. If you look at the pie chart on the left, you'll see that 1 in 10 calls to an ambulance service in England is dealt with by telephone advice alone, with a paramedic usually giving advice. About 4 in 10, an ambulance is sent, but a paramedic discharges the patient at scene, normally at their own home. So about half of patients who call an ambulance service are not taken to an emergency department in that ambulance. So this triage service helps to manage demand for an ambulance and manage demand for emergency departments. If you look at the graph on the right, you'll see pairs of bars for the 11 ambulance services in England. And the blue bars are telephone advice only. And you'll see there's quite a bit of variation in terms of the proportion of calls that are dealt with by telephone. And the red bars are discharged at scene. And again, you'll see variation. Now, a number of years ago, I looked at a graph like that, and the variation was larger at that time. And my question was, why do we have variation like that between ambulance services? Is it to do with the populations that they're serving? Are they tailoring the care that they offer to their population? But actually, when the NIHR funded us to look at that, we found it was more to do with their workforce than anything else. Services that had higher numbers of advanced paramedics had higher non-conveyance rates. And it was also not simply to do with the type of workforce that they had, but how they valued and used that workforce. So the final sort of strategy I want to talk about, and the contribution that researchers can make, is in just trying to understand why people are using these services for minor or urgent, non-urgent problems. And we've recently completed a study where we've identified that some of the reasons are actually related to how the system is set up. If people can't get a GP appointment, then they will go to an emergency department when they feel that they need to be seen immediately. It is also the case that sometimes they get a GP appointment and the GP refers them up to the emergency department, where the emergency department then thinks, well, actually, you're a bit too minor and non-urgent for us. There are also a number of patient-related issues, and the one that I want to just pick out of that list is stressful lives. That when we are making decisions about what to do when we come across an unexpected health problem, if we're not stressed, if we're not living in poverty, then we can make a decision that what we've got is minor. But when somebody is a single parent, living alone in poverty, something that seems quite minor to somebody else becomes an enormous stressor to them, and they look for the very simplest solution, and that may be calling an ambulance or making their way up to an emergency department when they could take, go to a pharmacist, for example. What solutions are there for reducing this kind of demand? Well, in many ways, when you look around us, we have lots of things in place. Both NHS 111 and NHS 111 Digital can help people to think about self-care so that they can look after their own health for their particular health problem and in the future. And we also have a number of ways of educating people. So for example, if you get onto the NHS Choices website, it gives lots of information about what to do if you've got some of these minor illnesses that people will often go to an emergency department with. Here's a solution we really, really do not want. This is monthly use of emergency departments in England. And if you look at the blue line, that's our main emergency departments. And you'll see this massive drop in April of this year. And that was COVID-19. And we have to look at that and say, well, is that a good thing or a bad thing? And it could be a fantastic thing in that people are no longer going to the emergency department with minor or non-urgent problems. But it could also be an issue that people with serious health problems are not attending an emergency department. I know Luella Vaughan has recently written a blog about how in her policy analysis, she feels that it's probably that minor non-urgent problems are not attending. But I think we've still got a question mark there about what's happened during COVID. But for me, it really brings to mind this dilemma that people face about balancing the risks and benefits to themselves, their families, and the health service when they have these health problems. I think I've been quite negative there, and I want to say that I'm actually very, very positive about the services that we've got in the UK. I'm very, very positive about the innovations that policymakers and service providers make. But they do face what we call a wicked problem. And this is a problem where every time you try to fix something, something else pops up somewhere else that creates a bigger problem. It's a difficult thing to address. But it can be improved, and it can be improved using multiple solutions, which is what our policymakers and service providers are doing. But I want to just end the talk by talking about two things that I think we could do more of. And the first is to just go back to that National Audit Office graph that I showed, where we see increasing use of these services, but we are not seeing the resources increasing at the same rate. And when we recently delivered a report to the NIHR about looking at demand for this system, our patient reviewer said, you cannot write about all of this without talking about the balance of resources to demand within the system. And we had to, actually, we wanted to change parts of our report to address that patient's concern. The second thing is, I showed a graph of how important general practice and primary care is to the whole emergency and urgent care system. Any small change in that system, in that service, is going to sweep through to the other important services of 999 and emergency departments. And so I would say we could look more to strengthening primary care in order to help this whole system of emergency and urgent care demand. Thank you. Now, I'm just going to pass over to John Browne.
Thank you, Alicia. So my talk today is going to be about changes to the urgent and emergency care system in Ireland over the last 20 years, with a specific focus on the downgrade of smaller emergency departments. First, a little bit about me. Despite my accent, I'm from a small village on the southwest coast of Ireland called Ballyduff. I am the son of Irish immigrants, and I was born and raised in London, but moved back to Ballyduff when I was 14. My mum and dad still lived there. It's a beautiful part of the world, and here you can see a round tower just outside the village, which dates from around 1100s. Ballyduff is hard to get to, and indeed, the main road into Ballyduff is now shut because it's in such a poor state, and we have to take a lengthy diversion to get into Tralee, which is the nearest large town. Here is a map of the population distribution of Ireland. Cities are in red and highly rural areas in dark green. But you have other more complex areas, such as rural areas, which are highly dependent on urban areas for employment, and these are the lightest areas. The point I'm making in this slide is that settlement is complex. It's not just a matter of neatly spaced cities surrounded by countryside. And the pattern of settlement varies across the country. This complexity means that a solution that works for one region won't work for another, so one size won't fit all. Centralising all emergency care could work for the region around Dublin, for example, but where would you put the hub hospital in the southeast of the country, which has no obvious central urban focus point? And what do you do with Donegal in the northwest, which is virtually cut off from the rest of the country by the Northern Irish border? And what do you do with the Midlands, which has a large number of medium-sized towns, none of which is the obvious focal point? Ballyduff, where I'm from, is here on the coast of Kerry, and here is our local hospital in Tralee, about a 30-minute drive away. And here is Cork, where I now live and work, and where the tertiary hospital for the southern region is located, about a 2-hour drive from Ballyduff. I'm showing you all this because there's a constant question mark over the sustainability of the hospital in Tralee. And at one point it was proposed that all acute services, including the 24-hour emergency department, should be closed and transferred to Cork. What is the best configuration of acute hospitals in a country like Ireland, which has so much geographical variation in settlement patterns? Hospitals vary in size and purpose and serve different populations and contexts. Smaller hospitals like the one in Tralee tend to be less efficient, harder to staff, and less safe for a small group of low-volume critical cases, such as patients who've had major trauma. Measures to address this are controversial. One approach is to downgrade emergency departments at smaller hospitals and centralize all emergency care to larger hospitals. This lengthens journey times and can take acute beds out of the system with spillover effects, such as overcrowding in the new hub hospitals. It also imposes a disproportionate access burden on rural, older, and poorer patients. Patients exactly like my mum and dad, who both have chronic conditions and are in their late 70s. Most importantly, the broad impact of emergency department centralization is hugely understudied, and there's no strong evidence that it improves safety for the populations affected. Only the closed study by Emma Knowles and her colleagues from Sheffield come close to a proper population level assessment. Despite the poor evidence base, urgent and emergency care has been reconfigured to varying degrees across the Republic of Ireland, and most of it happened between 2009 and 2013. These initiatives were done on a piecemeal regional basis rather than for the country as a whole. In 2 regions, this involved whole system integration, for example, bypass protocols for stroke, STEMI, and major trauma. But the largest initiative was the reduction from 39 to 29 emergency departments. This happened at a time of economic stress caused by the 2008 economic recession, when other conflicting policies, such as bed closures, staff cutbacks, and pay cuts were introduced. Here you can see the current location of emergency departments in Ireland, and it's worth noting that there are still 9 in Dublin, a city of around 1.2 million people. The black dots show you the 10 emergency departments that were downgraded to local injury units or urgent care units, which are open on a limited basis. Reconfiguration was most extensive in the southern and midwestern regions of the country, where 6 smaller emergency departments were closed, largely affecting rural populations. The reconfiguration agenda is alive and well in Ireland, and there are plans to downgrade as many as 9 more emergency departments. And here you can see the head of our health service, Paul Reid, advocating for fewer emergency departments at the start of this year's general election. The push to downgrade even more emergency departments is happening at a time when public healthcare services in Ireland, like the UK, are under extreme pressure. We've up to 1 million public patients on waiting lists and a chronic trolley problem in emergency departments, especially in hub hospitals for the reconfigurations in Cork and Limerick. The situation has got so bad in the Limerick Regional Hospital that the public are sometimes advised not to attend. And one can only wonder what the residents of Clare and North Tipperary make of this, given that their own emergency departments were centralised to Limerick. This is all happening against the backdrop of rapid population growth. Our Central Statistics Office projects the population in Ireland may grow by as much as 2 million by 2051, and this will happen in all regions, not just Dublin. Over the next 10 years alone, the need for inpatient public hospital services is expected to increase by more than 1/3. That all brings me to the SIREN research programme, which I've led over the past 7 years and which was funded by the Irish Health Research Board. The aim of SIREN was to describe and evaluate the development and performance of different urgent and emergency care systems in Ireland. It's a large mixed method study which has produced 10 papers so far, and they're all summarised in this paper, which was published in the Future Healthcare Journal earlier this year, edited by Llewellyn Vaughan. And if you haven't read it, I really strongly recommend that you do, because it has a fantastic range of papers about the challenges faced by small and rural hospitals. So we carried out a qualitative interview study with 175 proposedly selected internal and external stakeholders across all regions in Ireland. The term internal stakeholders refers to HSC clinicians and managers who were involved to varying degrees in the reconfiguration process. External stakeholders were a heterogeneous group of GPs, pre-hospital care providers, civic groups opposed to reconfiguration, local politicians, and media. We also performed a qualitative analysis of the major Irish policy documents in this field. And here are the main findings. First, we found little evidence of substantive engagement by planners with the public and other civic partners. This was one of the root causes of a prolonged period of conflict between health planners and campaigns to prevent hospital downgrades. Some of these, for example, to protect the local hospital in the Midlands, were successful. Others were not, and as a result, we now have very different models of provision across the country. Dublin, for example, has 9 emergency departments for 1.2 million people, whereas the Midwest only has 1 for 400,000 people. When it came to debate, internal and external stakeholders constructed their own lines of argument. Safety and efficiency were the key drivers for internal stakeholders, who also decried the role of local politicians and a misinformed public in thwarting their plans. External stakeholders emphasized access and the value of a fully functioning acute hospital to the life of the community, but they also disputed the way that safety and efficiency were framed by internal stakeholders. Here are a list of questions which were brought up during the interviews with external stakeholders, and which I think are really important and show that the people on the receiving end of reconfiguration have many legitimate concerns. First, volume outcome literature that underpins the safety argument only applies to a tiny proportion of all the people who go to an ED. So what about the rest? For example, frail older people who represent a rapidly growing proportion of all ED attendees. Why is reaction to safety incidents at large and small emergency departments so different? To the extent that it almost feels as though planners and regulators want things to go wrong at smaller hospitals to confirm their prior beliefs about their safety. Why is the Jenga effect of ICU and acute surgery downgrade so binary? And why are there no compromise solutions? Here I mean the way in which many functions at an acute hospital cannot be sustained, especially emergency departments, if there's no ICU or acute surgery team on site. What about the other harms of centralization? Why are we only looking at mortality in a small group of patients? So for example, environmental damage due to extra traffic, economic damage to smaller towns, overcrowding at the larger ED hubs, and disruption to local care relationships. Why are they so easily discounted, and who gets to do the discounting? If efficiency is important, why do we still have 9 emergency departments in Dublin, all in close proximity to each other? And finally, what about the other agendas? For example, the preferences of training bodies and medical schools, which are hidden from view but strongly influencing planners. I'm going to move on to our quantitative studies, and here you can see the overall trend in case fatality ratios for a basket of 16 serious emergency conditions, including stroke, heart attack, and major trauma over the period 2002 to 2014. The overall trend is very positive, and this is great news and a credit to the people who work in all the emergency departments, large and small, across the Republic of Ireland. Mortality has fallen by nearly a quarter over the period. However, joint point analysis revealed a significant break in the linear trend around 2007. Before 2007, case fatality had been falling by 3.4% a year, whereas after 2007, the rate was only 1.2% a year. In this slide, I'm showing you the case fatality ratios at regional level to see if reconfigured regions had the expected improvement in survival compared to regions that did not reconfigure. Because remember, reconfiguration is supposed to improve outcomes in patients. The y-axis depicts the annual percentage change in case fatality rates, and higher numbers indicate a worse trend. As you can see, there's no obvious pattern. In fact, all three types of reconfiguration are represented above and below the national average. The best performing region was the West, which had a very limited amount of reconfiguration and only closed one small emergency department in Roscommon. And they still retained 5 emergency departments for a very rural area. The worst performing region was the Southeast, which also had undergone very limited reconfiguration. Neither the Southern or Midwestern regions, represented by the green dots, stand out as overperformers, despite having done the most extensive centralization program. Interestingly, once you examine the data at a sub-regional level, the 5 counties with the best performance were Mayo, Sligo, Louth, Donegal, and Kerry, all of which retained their local emergency departments. These emergency departments all serve relatively small populations and yet significantly outperformed the national trend. Now, here's the interesting thing. When I discussed these findings with one of the most senior people in our public health service, a person who had been heavily involved in the reconfiguration program, they told me the results support the case for centralization because it shows the additional travel times have not increased mortality in regions which had closed some emergency departments. When I responded that I thought the whole point was to increase survival because the smaller emergency departments were supposed to be so dangerous, they responded that it was actually about efficiency and how we can't afford to have so many small units. At that point, I told them I had led another study, which I haven't got time to show you here, that found reconfigurations were no more efficient than others. And this is a common finding also for the UK, and Candace Emerson has demonstrated the same thing about a lack of efficiency gains. The person I was talking to then paused and said, well, anyway, no one wants to work in these hospitals, so it's all a moot point. And this conversation really opened my eyes to the way that research findings can be weaponized and framed in this field. Here's another example of this problem, this time using fantastic research conducted by colleagues at the Royal College of Surgeons of Ireland. The study found that there was no difference in survival rates for emergency abdominal surgery between low, medium, and high volume hospitals in Ireland. In fact, the survival rates are almost identical. But again, look at how the study was interpreted. This is a direct quote from a newspaper interview where the study is interpreted as strengthening the case for having fewer acute surgery centres in Ireland. This brings me on to the current pandemic and how important it is to be aware of the way in which problems can be framed. There are already suggestions by senior health administrators in Ireland that the pandemic has highlighted the need to consolidate intensive care into a smaller number of hospitals. This will inevitably lead to the downgrading of other services, such as emergency departments at the smaller hospitals. In response to this, I'd like to propose 4 other ways to frame the problems caused by the pandemic. First, is the risk of virus spread increased by centralization, for example, from urban to rural communities? Second, does centralization increase fragility, for example, by having large chunks of capacity taken out by outbreaks in large hospitals? Third, will the global market for medical talent in the English-speaking world be seriously disrupted and create the opportunity to retain medical trainees for smaller hospitals in rural areas which were previously undesirable? And fourth, will settlement patterns shift away from cities because of the increase in remote working? So to summarize the SIREN findings, first, this is a complex contested policy arena and the terms of engagement are not clear. Evidence plays a confusing role, especially the volume outcome literature. It's not clear what the rules of the game are and the goalposts keep changing. There was no evidence in SIREN that reconfiguration improved outcomes, but the design is not perfect to test this hypothesis. The trend break we observed is probably a floor effect or recession related. But the mortality evidence, when we look at the sub-regional data at county level, does not point in one direction. And the important point here is that policy solutions are not obvious. And finally, here I've listed some things I've learned while leading the SIREN research program, which might be useful for anyone who wants to get involved in this field, starting with the do's. So first of all, understand that the evidence rarely maps perfectly to every context, and that counterfactuals, which involve moving large populations from one context to another, are unlikely to produce hypothesized outcomes. Second, accept we need multiple perspectives on purpose, success, and failure. Understand that all evidence is framed and there's no perfect frame. Realize that it's dangerous when powerful interests are the only people doing the framing. And finally, make a sustained commitment to working on these complex questions, because it takes a long time to understand what's really going on under the surface. And eventually you may be able to play an important role as someone who can bridge the divide between healthcare planners and the public. And finally, the don'ts. Don't start with lazy stereotypes about urban and rural and big and small that you might have picked up from your colleagues. Don't let the tail wag the dog, i.e. focus only on the most severe patients, medical workforce preferences, or the agendas of small subspecialties. Think about everybody who uses these services. Don't change the goalposts when the findings are annoying. Don't buy the hype about top-down restructuring plans delivering enormous economies of scale or eliminating avoidable admissions. Any gains you see are likely to be very modest and with the potential for unintended consequences. And finally, don't overgeneralize your conclusions and dismiss geography and the importance of place. Instead, you're better off treating each evaluation as a case study. And here I'd just like to list all the people who worked on SIREN. There are too many to question by name. But I'd like to acknowledge that a lot of the work we did on SIREN was shaped by academics who worked on similar problems in the UK, including Alicia, John Nichol, and Naomi Phillip. And I should also note that a lot of my thinking on these issues has been shaped by reading the work of people like Helen Stewart, Lorelei Jones, Trish Greenhouse, Justin Parkhurst, and obviously Llewellyn Bourne. Thank you.
So thank you very much to two fascinating talks from Alicia and John. We're going to move on to a question and answer session now. Before we do that, I'll just give a little feedback from my own take on that. Really important lessons to take forward in research and policy in emergency and urgent care. The biggest thing I picked up there sorry, was the competing tensions. This is such a complex area for policy, for practice, for service delivery, and for research. And there are competing tensions between the different providers within the system, the ambulance service, the emergency department, the GPs, and so on. Regional tensions, as John talked about very persuasively, between localization and centralization of services. Case mix, what's good for one type of patient with one type of condition, problem, and urgency may not be the right thing for another type of patient. Stakeholders, what works for one might not work for another part of this system. Whose outcomes are we looking at, as we said earlier, and whose costs are we looking at? So I'm going to move on to, we have a bunch of questions here. And I'm going to start us off with the most popular one, which is what lessons can be drawn from reductions in emergency care use during the COVID-19 pandemic? How can services ensure demand is appropriate, e.g. ensuring people in need of healthcare still express it? Who would like to have a go on that first? Alicia.
Yes, so this is something that has been of great interest to us in Sheffield, and indeed we submitted a project to explore people's decision making and what affected people's decision making during the pandemic and the lockdown in the UK. As I said, Llewellyn Bourne has done a sort of policy analysis and concluded that we probably is a positive issue in that people with minor problems didn't go to the emergency department. But I think we actually don't know, and we need to look at that more seriously. I know the health services themselves were very concerned about some people with serious symptoms not making their way to an emergency department. I would say, could we have some research about that, please?
Thanks, Alicia. And John?
Just to pick up as well, I do think it's dangerous to draw the lesson that we don't need, these services because people stop using them for a brief period of time. I think in Ireland, most of that was fear, which manifested in people who needed care not going to the emergency departments. There's definitely an effect of people, not being able to go to pubs and not driving cars and not being engaged in sport as well. But I think one of the big things we're struggling with here is how to provide emergency department care post-pandemic, because they're so crowded already. There's so many people on trolleys, and social distancing is going to make that intolerable. And this is exactly the wrong time to think, right, aha, we've identified a service that nobody needs.
Thank you, John. And perhaps you'd like to comment on the, I've seen this week news about a pilot in NHS England of an appointment system where people should make an appointment through the 111 service, I believe, before attending the emergency department. That service is being piloted, I think, in a couple of trusts at the moment in England and may spread more widely. Do you have any comments on that?
This is Alicia's bailiwick.
Sorry, John?
This is Alicia's field, definitely.
Alicia, go. Yes.
Yes. I always think it's good to try things out, pilot them, see what happens. I worked in a health authority in the mid-1990s where they were talking about doing something like that back then. It's a model of care that is used in the United States of America, where you have to call your healthcare provider in order to get into the health system. I'm all for piloting things, evaluating them, see what benefits they give, see what problems they introduce. So as long as it's being evaluated, I think it's great.
I think that's the crucial point, isn't it? All too often in the UK, we've seen initiatives introduced before evaluation and before research has taken place. And by the time we're able to do research, the innovation has spread everywhere. And it's very, very difficult to draw back, isn't it, from an innovation which has already been implemented.
I think that's right, Helen, that I've talked a lot today about setting up pilot schemes and evaluating, but in practice what tends to happen is that a service becomes a political animal and suddenly it's everywhere, it's rolled out nationally before the results of any evaluation are available. And I think with certain things, and I think particularly asking people to call before they attend an emergency department, you really do need to have a pause and a think about what the research tells you before you think about what to do in terms of rolling it out further.
And yes, go ahead, John.
I think the other thing we learned a lot about in Ireland is to be very skeptical about the idea of perfect implementation. So, perfect implementation implies, obviously at the technical side, we'll get it all right. But it also implies that, nothing else is going to go wrong in the world in the meantime. There won't be any recessions that mean health budgets get cut. And I think you have to be super skeptical and give yourself big safety nets, because what happened was we reconfigured in the South and the Midwest in the middle of the post-recession. We just didn't have the money to increase the capacity in the hospitals, and that led to an almost disastrous situation in Cork and Limerick.
So what are the lessons for researchers in this environment? It's very unusual that we can carry out a randomized controlled trial, isn't it? The service change.
Well, I think the one thing I've learned, in fact, there's a very good paper that's just appeared in the Emergency Medical Journal looking at reconfiguration in the northeast of England. And I think, that there are lots of challenges that were faced by that paper. So one of the things is you have to account for trend. Things are getting better all the time. If you do a before-after study where mortality has fallen by 0.5% over a couple of years, the likelihood that that has anything to do with reconfiguration is minimal, because things are just getting better anyway. And you have to count all the patients. And this is one of the things I really learned from Alicia and John Nichol and their team, is that you can't just focus on the people who end up making it into the new hub. What about all the people who've somehow managed to diffuse their way into other services? And what was the outcome for those patients when you try and shift patient populations from one place to another?
Did you want to add to that, Alicia?
No, that was a great answer.
Okay, we'll go to another question that's been upvoted, which is a new term to me. So if we compare with other European systems, the UK has low numbers of hospital beds, general and acute, very high levels of occupancy, and waiting times for GPs are relatively long. Isn't the underlying issue a lack of funding and capacity in both primary and secondary care? Alicia, I think you alluded to this in your talking.
Yes, I did. I think this is a serious issue, and I think that these international comparisons are really, really important. Yes, I think we really do need to look at capacity. I mean, something that I have only mentioned very briefly today is around workforce. We're asking our workforce to do more and more work under more and more stressful situations, and they are doing an amazing job. You know, if you look at them close hand as part of research or making use of health services, you just have to be amazed by them. And I really think we need to start to get that balance of demand and resources just better calibrated, better balanced. So I would agree, internationally, we are looking good on outcomes, but poor in terms of the resource demand balance.
Yeah, and it's even worse. It's actually far worse in the Republic of Ireland. Our bed numbers are a joke, and that's what always makes it so curious to me, that anyone thinks the solution to these problems is to close more services. You know, one of the reasons we have smaller hospitals in Ireland is because they haven't been funded properly. They haven't got the beds. They haven't got the staff, and that does, you know, mean sustainability is a big issue. But a lot of that could be solved if they were funded at European levels.
So there are a lot of initiatives, recent initiatives, to diversify the workforce within the emergency department, particularly. You have to wonder whether this is really to improve care and outcomes, or whether there's a financial incentive to this. Alicia.
Yeah, I mean, I think that we've got shortages of workforces. So there's a sort of practical issue of how can we deal with that. I mean, I rather like the approach to diversifying workforce, but I would hope that it would come alongside making sure that we're training enough of the workforce. We're allowing them to work in a context where they feel that they can have a full career there rather than leaving early, so that we've got retention issues. So I'd like to see more diversity, in fact, but alongside also seeing more attention to how we're treating the workforce and the numbers of workforce that we have.
Thank you. And John?
Yeah, I mean, just echoing the points Alicia made in her talk, we have to get away from this idea that there are alternatives to spending the right amount of money and hiring the right number of staff. Both of these things have to happen at the same time. We need innovation. We need different models of care so that we can optimize our approach to demand. But that doesn't mean that we can then downgrade services and have fewer staff. These two things have to happen at the same time. Like, Ireland's population is going to grow by 30%. You know, there's nothing you can do about that. You know, the tax base is going to grow radically, hopefully, when we emerge from this recession. That provides the opportunity for the right amount of healthcare resource. I do think, like, there has in the past been an unwelcome attitude towards what to do with those resources. And I think sometimes that is cynically used in the larger academic medical centers to say, right, we do accept we need capacity increases, and we'll just pile more staff and more beds into the center, into a smaller number of very large hospitals. And I think you're really kind of pushing on a string with that solution.
And the next question leads nicely on from that, which is about the role of community pharmacists in this. Is there a bigger role to play? Yes, Alicia.
So people have been talking about this for decades. If we use community pharmacists more, people would use general practice less. May go up to the emergency department less, but we've seen sort of no evidence of that. And I think I would probably like to see a reflection on why the population doesn't use community pharmacy in the way that community pharmacy would like them to be used. I'm sure research has been undertaken. It's not my area, but I do think there needs to be a reflection about somehow the mismatch in expectations in the population and the service providers there.
John, would you like to add to that?
I got nothing to add to that. That's exactly what I would have said.
Okay, I do like this question. It's not quite the next one, but it's about how good are patients at assessing the urgency of their problem. Alicia wants to answer this.
So first of all, if you look at who goes up to the emergency department and what proportion of them are deemed to have sort of very minor problems that the service wouldn't really want them there. It's Colin O'Keefe has done a great piece of work and showed it's about 15%. So that means that 85% of people who pitch up at emergency departments have made exactly the right decision. I mean, if you look at the people calling an ambulance service, 1 in 10 of them are streamed to telephone advice only. So all in all, I think people are making a pretty good decisions about where to go. What we're trying to do is hone that decision making, try and take this minority of people and understand more about how we can manage them. Because although it's a relatively small proportion of people who we'd like them to make different decisions, it has an enormous impact on the system when the system is already full and we're sort of working to capacity. So I would say, all in all, congratulations to most people, but I think we can help people some people make different decisions.
John?
I think I agree with all of that. I do think there's a need for a broader conversation about the purpose of emergency departments, which needs to happen at a national level and can't just be defined by a group of managers or emergency department consultants. To what extent is it a safety net? If you talk to a lot of emergency department consultants, they will say, if you apply a retrospectoscope, obviously very few patients needed to go to the emergency department, but that's not what the service is for. The service is about, in most instances, ruling out the risk of some serious underlying condition, emergent condition. And I think it's about, we need a conversation about that so that it's clear within the public and within the service exactly what's going on. And sometimes you'll often hear people say, oh, this service is not fit for purpose. Well, tell me about the purpose. Let's have that conversation. And who's getting to define the purpose of the service?
Could I follow that up a little bit? Which is just thinking through, if most people are making the good decision, the correct decision about the place to attend for their emergency, and volume is rising all the time, does that mean that we've got more emergencies in more people happening year on year?
Well, I think yes, because obviously the population is growing is one problem, and the population is aging, and then underlying that you have a series of other, behavioural changes and changes in case mix, which are lending themselves towards more people requiring these services. And I think that's an important question, because we often think about these things as just being technical flow problems through the system. So for example, if we see a big leap in older patients with UTIs presenting to emergency departments and needing admission, the first instinct, I think, from a lot of managers is to think, well, what's gone wrong at the primary care level? And not to think, well, hang on a second, maybe there is some underlying population health issue here that's increasing this demand, and that should never be discounted.
Thank you. Alicia, did you have a comment on that?
No, I'm very happy with John's answer.
Okay. This also follows on from it, I think, which is how big a problem is people using emergency care with health problems which should have or could have been picked up earlier, such as cancer symptoms? Who wants to answer that? Alicia, go ahead.
I think I'd have to say I don't know, because it's not the focus I have tended to take in my research. And I don't want to start talking about something that I don't feel expert in. I don't know whether John has
I've done nothing on that, and that's.
What about yourself then, Helen?
No, I agree. I don't think we know the answer to that question. But but it may also really be impacted by COVID-19. I understand that GP referrals for cancer have really dropped enormously during this period. So that may have knock-on effects in the next months or years.
Yeah, I will provide you with an anecdote, which is that my dad had a suspected mass last year and was referred in. This is post-ultrasound, ended up being a gallstone. But you do see quite a lot of patients who end up being cared for through that route, because he was jaundiced and he had pain. And, in an ideal world, that wouldn't happen. There would be an alternative pathway. But in that instance, in that moment, I think the service worked very, very well. And that was exactly the right way for him to be cared for.
Okay, I'm going to move us on to our last question, which is really, what's in a name? There's quite a lot of different services being set up, walk-in centres and 111 and so on. I'm not familiar with the ones in the Republic of Ireland, but I'm sure there are as well. And the public can be quite confused between the array of services on offer. So what's in a name? Alicia.
So I think this is an issue. In Sheffield, we've done a lot of research talking to the general population about their use of emergency and urgent care. And you can have a focus group where you sit there and NHS 111 or NHS Direct as it was has been up and running for 6 or 7 years. And in that focus group, half the people have never heard of it. And the other half is educating them about, oh, you can phone them up, and they go, oh, can you? That's it. And there's also a sense of worry about, even if they know that you can go to a minor injury unit, can you get an X-ray up there? What if they went up there and they really should have gone to the emergency department? Why don't they just go straight to the big fella? Let's go to the emergency department, because we know that we can get what we need there. So adding to the system can cause confusion as well as give choice, and can also affect equity in that some people are more aware of some services than others. It's just one of those things where you can never get something 100% right, but I do think that we have to think about the additions that we're making and the things that the names that we're using to call things. So for example, when walk-in centres were introduced, we also had primary care centres being introduced and urgent care centres. Well, gosh, as a researcher, even I struggle to know the difference. So that it does sort of affect how the general population understands the system and therefore can make a good use of the system.
Thank you. And John?
Yeah, I think this is a really important issue. And I think there's a lot to be learned from the switch from A&E to emergency department. So why did that happen? It wasn't that the public were calling out for this. This was done essentially because I think there was a kind of a brand issue here. The specialty, particularly emergency medicine specialty, thought that it was inappropriate to have the word accident in the title. It's not their emergency department. It's not their A&E. It's not their call to make. Now, I mean, I work with fantastic emergency medicine consultants, but this does irritate me. If the public want to call it A&E, it's A&E. It's their hospital. It's their service. And one small specialty can't, demand that kind of brand control for something so important. And you see, I think that lesson should have been learned, but it wasn't when we came along to local injury units, urgent care units, minor injury units. It's too top down. There's not enough consultation with the actual end users. And if the end users want to call it a particular thing, a bugbear of mine is that Tralee is now called Kerry University Hospital. Why is it called Kerry University Hospital? Someone in the centre in Cork decided to change the name. It doesn't have that identity or sense of ownership from people in Kerry, and they don't call it Kerry University Hospital. They call it Tralee General Hospital because that's its name. And I do think we need to learn these lessons, but we seem to never be able to learn that important lesson about community ownership.
Thank you. Well, I'd like to thank both of the speakers and the people who have put up questions. Great questions. Thank you very much. It's been a really fascinating, excellent session. I've really enjoyed chairing it. Thanks to HSR UK for hosting this, and goodbye, everybody.